My name is Ajit Sachdeva, and I'm the Senior Vice President for Education at the American College of Surgeons. And I also have the distinct honor and privilege to co-chair the American College of Surgeons Academy of Master Surgeon Educators, along with Dr. L.D. Brett. I'd like to welcome all of you to this very special fireside chat. We are honored and very privileged to have with us Dr. Gerald Healy, who is a former chair of the Board of Regents of the American College of Surgeons and also the past president of the college. In fact, he was the first otolaryngologist to be a president of the college, and he has been an icon all along. And when I joined the college 24 years ago, I was so impressed by Dr. Healy and remain impressed until today with all that he's done and all the difference he has made. Dr. Healy has been a visionary. He's been a mentor to many of us and certainly been a very dear friend to me. And he thought about the use of simulation even before it became popular. He proposed a new paradigm for M&M conferences, and I had asked him to chair the systems-based practice task force for our division soon after I joined the college. His focus on patient safety and patient care has been very, very powerful. And I would also like to give him credit for something that is little known to people within the college. He is the one who started propagating the term, the house of surgery. He was the first one who proposed that term to bring in all the specialties under one umbrella to make a difference in patient care. And before I hand the floor over to Dr. Shabahang, I'd like to thank our staff, Dr. Patrice Blair, who is the Associate Vice President of the Division of Education, an affiliate member of our Academy, Kate Kimmick, the manager of the Academy, and Caroline Forker, the administrator for the Academy. Dr. Shabahang is going to be moderating the session. He is the world's expert in these kinds of sessions. He does a wonderful job. And Mo is the Chief Medical Officer and Head of Surgical Services within the WellSpan Health System. You see that logo behind him. And we are so delighted to have Mo moderate this session as well. So Mo, with that, I will turn the floor over to you.
Thank you so much. I appreciate it, Dr. Sachdeva, and thank you, Dr. Healy. Maybe we'll start with the slides and share the slides with you. Just some housekeeping. Please feel free to type any questions. We'll try to incorporate that into the conversation. If I don't get to it, my apologies for that. Next slide. Just a reminder that all of these fireside chats and grand rounds are on the Academy website. Please feel free to watch a recording and enjoy those. The next session is going to be November 20th. I think we're going to be talking about global surgical education, and the next fireside chat is on December 8th with Dr. Scott Levin. Excellent. Let me just do a formal introduction. Thank you to all of our participants tonight. Dr. Gerald Healy is the Emeritus Surgeon-in-Chief, Boston Children's Hospital, also the Emeritus Healy Chair in Otolaryngology, Professor of Otolaryngology at the Harvard Medical School, and also the past president of the American College of Surgeons. Jerry, welcome, and thank you so much for joining us tonight.
Well, I'm delighted to be part of this wonderful fireside chat where we reach out to all of the house of surgery, as we just mentioned and Sach just mentioned. So I'm honored to be here, and I'm looking forward to our discussion.
Absolutely. So let me first start with that house of surgery. I know we're using that terminology. It was right. As I was at the clinical congress, there were all flags everywhere. Where did that come from?
Well, I became a regent in 1998 and served for 9 years in that capacity. And early on in that time, we had a meeting of the Member Services Committee, and we were trying to engage each other as to how we could make the college more attractive to specialty surgeons, people like my specialty or orthopedics or neurosurgery. And so I was sitting at the table with people and I said, well, we're really like a house, we're a home. What happens in a home? Well, a family gathers, they come together for common reasons, common purpose, but they're all different in many ways. But they have a focus, and that's what we are. We're a common place where people can gather from all specialties and have a common goal of patient care and other things that they have passions about. So why don't we call ourselves a house of surgery? And the house of surgery, a home is built on a foundation, and so the duty of the regents is to make that foundation strong and attractive, so people will want to live in the house.
Mm.
And so that's where we started it. It was just a simple conversation in a committee meeting. But, I was thrilled to see a couple of years ago the college latched on to this concept and is embracing it now and fostering this ability to come together under one roof, because it's the only organization where all surgeons are represented. We're not a siloed sort of thing. We have everybody there from all the disciplines. So that's kind of where it started.
Thank you so much. I'm sure many of us did not know that, and so great information. As we discussed in our prep session, much of your education, and not maybe all of your education and positions, were in Boston. And, there are multiple models. People sometimes move around, sometimes stay in one place. And one of the things that also stood out, and I was going to ask you about, is you had academic appointments at Boston University, Tufts University, and Harvard University. Just wanted to, both, start with your training and so on, and also the Boston connection and how that came to be, and any lessons from it for our participants.
Yeah, well, it was hard to get this guy out of Boston. I was born here, grew up here, was educated here, went away for the military, but I did come back to a position in 1974 at Boston University Medical Center. And I was very interested in pediatric otolaryngology. It was a blossoming subspecialty area of our specialty. And I got a call one day from a person who I just adored and was an icon always, and that was Dr. Judah Folkman.
Mm.
And Judah called me and said, we want to build a department of otolaryngology here at Boston Children's. Would you be interested? I hear you're interested in this area and so forth. And so anyway, he was a very persuasive man, as many of you who knew him realized and knew. And so I went there and I began to develop a program. But I insisted that even though that was a Harvard affiliated teaching hospital, that it was such a unique place and treated such unique disease in children that it should be open to the trainees of all the training programs in our specialty in the city. And that was at Tufts, at Boston University, and at Harvard. So we had residents come from all those hospitals and those universities and those programs. And I was fortunate enough to be the probably one of only two people ever to be given a professorship at all three schools simultaneously. And that was a special dispensation that I was given. And I think the other fellow was a neurologist. And that's how it evolved. But it was all centered around making sure that the trainees in all these places had an opportunity for this wonderful exposure at this world-class hospital.
That's incredible. We all know that in healthcare, that's not always easy to do that. So that's an incredible thing. Now, I know that you were initially interested in a cardiothoracic surgery, but you ended up going into otolaryngology, and I've enjoyed hearing the story about that and thought maybe you would share that.
Well, it is interesting. I did start out headed in that direction, but I became very concerned that the culture in cardiothoracic at that time was not a very friendly one. People seemed to be brusque and abrupt with operating room personnel, anesthesiologists. It just wasn't the kind of culture that I felt comfortable in. Meanwhile, I was observing these other folks in this specialty called otolaryngology, where the residents seemed very happy, and the chair was a delightful man who patients seemed to love, and he was great in the recovery room. I'd watch him, I'd listen to him. So I explored it, and I decided to make a change. Needless to say, the people that were running the program I was in initially were not very happy and didn't really embrace the idea of me leaving and switching to another specialty. So it was kind of a bit of negative role modeling, if you will, which promoted me to a more positive role modeling. And so I think the issue that you need to realize if you're a young surgeon is there is as much to gain by negative role modeling as there is by positive role modeling. You can see negative role models in a light where you can teach yourself this is not the culture you want to be embracing. The culture you want to be embracing is to be a positive role model. Always encourage young doctors to follow their dream and help them do that. And happiness in medicine is critical to successful doctors and good practitioners. So that was kind of why I made the switch.
This concept of negative role modeling is a fascinating one. Any and you've contrasted the positive and negative role modeling. Um, how much, you know, I just was going to ask you to elaborate on that.
Yeah.
Throughout your career, how much, what kind of balance do you think is out there?
Well, you know, the critical thing we have to be careful of as leaders in surgery is being a leader who doesn't tolerate bad behavior. And some surgeons, you know, just aren't comfortable in the setting of the operating room sometimes. They act out, they yell and scream, they may use profanity, and they forget that they're a professional. And they're surrounded in those rooms by professionals, nurses, anesthesiologists, maybe medical students, maybe residents, maybe fellows, and people are watching you. And what is the message you want to give to those people? The message is one of positive character promotion. And these people that angrily act out all the time and throw instruments and yell and scream and stamp their feet, that's a negative role model. And I've always felt strongly that if you're an astute resident or fellow or medical student or whatever, you watch those people and you say, I don't want to be like that one. I want to be a different one. I want to be like the person that's kind to everyone and patient and patience love. And he's abrupt, not abrupt, but, you know, embracing. So that's my sort of concern with negative role models. People are watching you. And one of the things I like to talk about when I discuss this is I say, you know, look in the mirror. It always helps sometimes to just take 5 minutes and look at yourself in the mirror and say, how am I being perceived every day?
Mm.
Is it positively or negatively? And I think that's a very good thing to do and embrace.
Thank you. Thank you for elaborating on that. Um, One of the other things that uh, you were the first in was you were the first otolaryngologist president of the American College of Surgeons. What was the significance of that for you, and any thoughts about that as you look at people who preceded you and have come after you in that
Yeah.
role?
Well, you know, the unfortunately, medicine sometimes can get little dicey, if you will. Turf battles begin to emerge sometimes. And when I was a young academic, there was serious turf battles between plastic surgery, cardiology, and general surgery. And it centered around head and neck surgery. And I watched that interaction. And when I became a regent, well, first I actually ran the board of otolaryngology for 9 years. I worked very hard to close those gaps, and I did, I think, do that. I was very, very blessed to have a great relationship with Dr. Frank Lewis, who was the chair of the American Board of Surgery, and Dr. Barry Noon, who was the chair of the American Board of Plastic Surgery when I was the chair of the American Board of Otolaryngology. And we really worked to mend those fences. And so when I became a regent of the college, I really worked hard to promote the concept that otolaryngologists were real surgeons. We weren't just people who took out tonsils and, fixed a few ears that were not quite right, but we had a lot to offer in the house of surgery. And it was really an important thing when I was asked to become president of the college. It meant something for our specialty. It meant that we were now being accepted in the house of surgery as real surgeons who could contribute and make a difference and help other surgeons be good doctors and consummate professionals. So it was a very important step, not just for me personally, but for my specialty and for the house of surgery to say, we embrace these guys, and the old days are over. We're all working together now in a very cohesive way for the betterment of patients. And that's who benefits from all this, is the patient. And we must never forget that that is the center of everything we do, the patient.
Excellent. I know you've said that many times. It's just it really it is a wonderful concept, and it seems so obvious, and yet I think sometimes we do forget. Can I ask you about your presidency of the American College? Aside from what you mentioned, what were some other significant moments, and what significance did it have in your life?
Right. Well, I visited 7 foreign countries and 31 states when I was president. And I did this because I really wanted to see what was going on in surgery in America, in rural America, in other academic centers. And I also wanted to see what was going on in surgery in other major countries around the world. And it was an enormous learning experience. For example, I had a great interaction with the Royal College of Surgeons of England. Professor Bernie Barbero was the president. He embraced me. We did a lot of things together, and the same with the Royal College of Surgeons of Ireland. The President Sullivan that year was a wonderful person, embraced me, but I learned an awful lot about what was going on. But one thing was very common. Patients with surgical disease are the same the world over. They're not any different in Korea or China or North Vietnam or England or wherever. So as surgeons, we have a common thread, the surgical patient. And I think the important thing is to learn from one another. And Dr. Sachdeva has been, for example, the master of that effort. I mean, his expertise in surgical education is world renowned, and he's brought that expertise to all these other colleges far and wide. And collaboration is something that I really, really learned during my presidency, and I strive to really make that work.
And you've talked about your experience kind of rising through the American College of Surgeons. Anything you want to share about that? I know you were on the committee on behavioral issues and so on, but anything about that about the way you kind of ascended the pathway to the presidency of the
Yeah.
American College?
Well, I have to credit Dr. Hardy Hendren, who was a world-renowned pediatric surgeon in Boston for many years at the Massachusetts General Hospital, and then as our chief of pediatric surgery at Boston Children's Hospital. And Hardy came to me one day and said, you should join the Mass chapter of the College of Surgeons. And I said, well, they don't want any otolaryngologists in there. It's all general surgeons. No, he says, you'd be a good contributor, and I think you should come. So he took me to a meeting, and I have to tell you, I was the only non-general surgeon there. But I thought, well, you know what? This is going to be a valuable experience for me because I learned so much in my career from general surgeons. And so I started in the Mass chapter. And next thing you know, they asked me to be the treasurer, I think because they had no one else who wanted the job. And then I rose up and I became a governor from the Mass chapter at the college. And I became president of the Mass chapter. And then Dr. Paul Ebert took me under his wing. He was a masterful gentleman who was the executive director of the college at that time. And I don't know, he sort of thought, gee, this guy Healy, maybe we can put him to work doing some things. And so he asked me to serve on some committees. And next thing you know, I was the regent for our specialty. And so it evolved, but it all started with Dr. Hendren encouraging me to come to a meeting of the Mass chapter. And what I say to those people on the program tonight, support your local chapters. They're very important. That's the ground rules, if you will, where everything starts. That's where the seeds are sown for the college and your participation in the college. And that was where it started for me. And I'm very grateful to all those people that helped me along the way. Packed my parachute, as they say.
That's so I want to ask you actually about mentorship um, and sponsorship and your thoughts and how did you do it? Any advice that you would give someone as far as the concepts of mentorship?
Yeah. Well, I think mentorship means a lot to many people. It's how I started in medicine. I became a doctor because of a role model, a mentor. He was my pediatrician. And when I was 5 years old, I first saw this guy coming to my house in the middle of the night with a little black bag. And I said, over the years, I want to be this person. And then, it grew and grew and grew. And then I realized that I can't always be a taker. I need to be a giver. And giving means passing on to the next generation what you have learned, what you have sort of embraced, and in nurturing them to take that and make it even better. And if you do it right, it is the most rewarding experience a person can have, especially in medicine, because you're taking the next generation and you're putting them on the right path and you're helping them. And it's not always a medical issue. It's sometimes a personal issue. It's a family issue. And they need to be comfortable enough with you that they can come and close the door and say, Dr. Healy or Dr. Smith or whoever it is, I need some advice about X. And I got to tell you, when that happens, it's one of the most uplifting feelings to be in that position as a mentor. And helping young people has always been a passion of mine because I was helped along the way. And I think it's important to pass that on to the next generation of people that are going to do surgical care for patients.
Absolutely. So when we talked a little bit about I know a poem that you have held that's been important to you, and I wanted to ask you the poem for our participants, and I may try to flash it on the screen, is called "The Dash" by Linda Ellis, and I wanted to ask you about that a little bit. What's the significance of this, and why is it something that's meant something to you, and I'm going to try to
Yeah.
share it as you speak.
Well, it's very interesting. I first heard about this poem at church on a Sunday morning in a sermon. And over the years, many sermons are kind of boring and you kind of fall asleep. But boy, this one got my attention. And as I listened to the reading of this poem, I said, what a message. What a message for all of us as doctors. Our dash. The dash is the hyphen in your headstone between your birth date and your death date. And really, it's what have you been contributing over those years? How will you be remembered? What is your legacy? Is it going to be a noble legacy that you leave behind? And what have you created? And I use this going forward in my talks to medical students, to residents, to staff physicians, to talk about what's your dash going to look like at the end? How will you be remembered as a doctor and as a surgeon? And that's what it's all about at the end of the day. It's about service, the service of patients and to patients. And so this poem was a very powerful thing for me to use, and I've actually used it at a funeral of a couple of friends and read it at those funerals because it is powerful and it has such an important message. And there's an interesting story about changing your dash from a negative one to a positive one. So there was a French guy, and I'll tell you who he was in a few moments, but in the 1870s, he was reading the morning paper and having his baguette and coffee outside Paris, and he read his own obituary. And the headline was the father of death is dead. And it was a horribly negative obituary about this man. And he was reading his own obituary. And the truth was, his brother had died, but they thought he died. And so they wrote his obituary. So he said, boy, I got to change this. Well, the guy was Albert Nobel, the father of dynamite. And he was being remembered in that article as killing thousands of young people in the wars and whatever because of dynamite. But how is he remembered today? Not for that. You say Nobel, they say the Nobel Prize. So there's a guy who was able to change his dash over the 10 ensuing years that he lived after he read his own obituary. So it's never too late to fix this dash and change who you are and how you're perceived. And I think that was an important, powerful thing for me. And passing it on around professionalism and all the attributes that a doctor should have as a skilled surgeon. So that poem was pretty important to me over the years.
Really a great poem, and that's why I wanted to flash it so
Yeah.
everyone could see it. So there's a question in the question box. I've been a pediatric otolaryngologist who finished my fellowship in 2008. I've loved the specialty immensely, but I've heard from certain other otolaryngologists that the pediatric subspecialty has not been held in as high a regard as other ENT subspecialties. What would you say to those other otolaryngologists?
Well, I think that I would say to them, you really need to learn more about what's going on in pediatric otolaryngology in the area of hearing restoration, in the area of airway reconstruction, in the area of genetic changes in hearing in loss and being able to manipulate genes to improve hearing in babies and so forth, hair cell regeneration. Pediatric otolaryngology is a vibrant and up and coming area. And I say to those people who perceive it negatively, you really need to learn more about us because we're an important part of the specialty. And these children, these special children we take care of. I like to characterize pediatric otolaryngology as a specialty where we do common things to exceptionally problematic children, and we do complex things to normal children. And if you think about it, that's what it really is about. This is not about taking out some tonsils in a community hospital. That's not pediatric otolaryngology. It's a very specialized area, and it usually is practiced in a big academic medical center or a focused children's hospital. So I would say to the person writing that question, do more to promote the specialty, give talks, give lectures, educate your colleagues about what you're really doing and what you mean to the specialty, because kids are very special people and they're not little adults. And I learned this from pediatric surgeons. Some of my greatest mentors, Judah Folkman, Hardy Hendren, these were pediatric surgeons who taught me a lot. And the same is true in pediatric otolaryngology. It's incumbent upon us to go out and promote the subspecialty to those that don't think we're that special.
Excellent. Another question is, from Dr. Paul asking, of all the three universities in Boston, which did you like best as a faculty member and why?
Oh boy, that's a hard question.
That's a hard question.
Yeah. Well, I did not really participate. One of the things that they made sure that you don't do is you can't be a voting fact. Even though I had the 3 professorships, I could only vote at one medical school, and that's only reasonable. You can't. There's a lot of conflict of interest when you're voting in 2. So I didn't do much at Tufts. I had an academic appointment there, but I had their residence, so I can't speak to Tufts. I think Harvard and Boston University are very different places. Boston University is a big sort of inner city type of hospital and medical school where people are trained. It's not heavily research. It's heavily in terms of training clinical doctors. Now, are there researchers that come out of there? And is there heavy research being done? Yes. Harvard is a unique place. It has immense amounts of research going on. It's a very vibrant place. So in terms of my learning experience, I would have to say Harvard, but I spent 37 years of my life there. The other 2 medical schools, I only trained in one, and I didn't really have a relationship, in-house relationship at the other. So I'm biased because I spent a lot of time in one place, namely Harvard.
Makes sense. Thank you for that answer. And thank you for the question. When we were talking, what advice would you give to new leaders who come into positions of leadership of a department or an enterprise? What would you say not to do, and what advice would you give them to do?
Yeah, that's a very, very important question, because I don't think we do a good enough job in training people how to be a successful leader. And many times you're thrown into a situation where, there's been a lot of problems and you're asked to solve them quickly and so forth. First and foremost, you need to know the culture and the history of the organization you're joining, because every one of these places has a different history and a different culture. So to think you're going to take the culture of Harvard and immediately transpose it into the culture of the University of Texas, and I'm just being hypothetical here.
Mm-hmm.
These are different places with different histories and different cultures. So the first rule of thumb for a new leader is take your time, don't be impetuous, learn the culture, learn the history, and gain credibility. Because I see too many people come in and they blow everything up in the first 6 months. They fire 6 people, they get all new staff and this and this and this. I don't think that's a wise way to go about things. Learn who you are, learn what's going on in the place you're about to lead, and then credibility is very important. You need to gain credibility, and you gain that by doing good work, taking good care of patients, and being a thoughtful, caring leader. Always have a shoulder to lean on. People be able to say, gee, I can go to Dr. Healy and, he'll help me solve my problem. He's there for me. So I think leadership is something that evolves. And you just don't get thrown in and suddenly you're a great leader. It's an evolution. And great leaders know how to listen.
Mm, mm.
Listen, listen, listen. People have a lot to say that is very important if you listen. And by the way, listen to the little people. Now, who are the little people? The people that not too many of the doctors and those of us in high positions spend a lot of time with. Like who? The carpenters, the electricians, the guys that sweep the ORs. They have a lot to teach you. They know what's going on. And by the way, without them, your hospital isn't going to function. So don't overlook what I don't mean to demean them by calling them little people, but they're not in big, important leadership jobs. They're not the EVP or whatever, but they're critically important. And they're usually very interested in talking to, if you want to spend the time, ask them about their families, ask them about their children, ask them how they're feeling. What's going on? How can I help you? It's an amazing thing. And by the way, feeling good as a leader, you really feel good when you can talk to those people and they smile back at you.
Such a great point. That's such a great point. So, what do you say to someone who says, this is all great advice, but it takes too long? I need to come and make impact in my first year. I need to make a difference. What would you say to that?
I'd say be careful. We're seeing people doing that on a national basis right now, right?
Yes, we are.
And that kind of approach can be very destructive. And you really need to gain the people's confidence. And coming in and blowing everything up is a big difference in being a football coach and a chief of surgery. The football coach comes in, he has to win the first year. Everybody's angry, and he's got to do it, and he's blowing everything up. But that's not surgery. Learn who your good surgeons are. Who are the problems? Where are the things that need to be fixed and addressed? So I'm very skeptical of people that want to come in and say, "Oh, I got to do this all in 1 year." I'm not sure you have to. And I think if you explain that when you're interviewing for the job, explain that to the leadership of whatever hospital it is or wherever you're going, they'll take that seriously. They'll take you seriously as a candidate because you're being thoughtful. You're not being impetuous. And being thoughtful and not impetuous, I think, is a characteristic of good leadership.
So you've talked about, the little people and this concept that maybe we haven't named it, but the concept of humility. How, obviously every surgeon has worked very hard to get where they are, and surgical leaders and researchers and educators have worked extra to get there. How do you keep humble in despite all the accomplishments?
Keep looking in the mirror.
And what do you see in the mirror?
Well, that's a good question, and the question is, you're the only one that can answer that if you're honest with yourself. Now, let me just tell you about a recent experience I had, and I won't name any names, but I had a medical problem, and I went to see what I like to characterize as Dr. Zeus, the god of surgery. And I won't tell you what the surgical problem is because I don't want to identify people, but it's characteristic of what not to do. So I never tell people when I'm visiting a physician for the first time that I'm a physician because I want to find out how they treat the real patient that comes in. Not Dr. Healy, but Mr. Brown, Mr. Smith, whoever. So the encounter went the following. I saw the physician assistant for about 20 minutes, and I was escorted in to see Dr. Zeus, who arrived in the room, said, "Good morning. Hi, I'm Zeus. And, oh, I see you did X. Let me look at your scan here. Oh, yeah." He said, this is a real bad problem. He said, "The only thing that can fix this is surgery. So let me tell you how this works. I've done tons of these. I will see you on the morning of surgery. My PA will explain how the operation is going to be done, and I'll make an appointment with my office to call you and set everything up." And he gets up to leave. Now, how long was that? About 12 seconds? That was my encounter.
Wow.
I turned to him and I said, "Doctor, I think you need to have a seat. I want to ask you a few questions." And the final thing I said to him was, I'm going to disclose something to you, doctor. I was a surgeon for the last close to 40 years, and I never operated on a patient I didn't examine. You never put your hands on me. And he said, "Well, my PA examined you." And I said, "So you're going to operate on me on the basis of an examination done by someone else? I don't think I care to be cared for by you. So you have a nice day." Now,
Well,
that is not what we want to produce. This guy is pretty famous. I I call these doctors Dr. Zeus. And you're, presenting yourself as the Almighty. Patients need a kind hand on their shoulder. They need to be engaged, connected to you. I had no connection with that person. So if anything went wrong in that surgery, if I allowed him to operate on me, he had no relationship with me. And so I'm going to be angry. Don't have that be your surgical practice and be your surgical career. Be someone who connects with patients, lets them feel, oh, you care about them and you're connected to them and so forth. But we're becoming too busy. We're becoming RVU driven. That's piecework. Now, the young doctors don't know what piecework is. But back in the last century, these young women made blouses and they were paid 25 cents for each blouse they made. So that's piecework. Each piece was what generated income for them. So the more pieces they made, the more income they made. That's the RVU system now. It's a dangerous system because it's not allowing doctors sufficient time to really connect to their patients. And it's so critical. It's so critical to connect to the patient.
I'm sure those comments are resonating with many who are on this program. In view of that, I mean, you brought up the RVU issue, which really is a very vexing issue. What do you see as the problems in healthcare? You've been in leadership roles. You've been the leader of a major organization such as the American College. When you look into the future, what worries you the most?
The real disparity in healthcare across our nation. We have one of the greatest medical systems in the world. We have one of the greatest medical education systems in the world. People come from all over the world to train here in surgery. And yet, some of our patients don't have access to this. We don't have a sort of standardized system of quality and excellence. If you walk out to the airport tomorrow and you get on a flight, you put trust. You don't know who's flying that plane. You've not seen them. You don't know them. But you have trust in the industry that they have vetted those people sufficiently and trained them and re-examined them and so forth over time that you can trust them. We don't have that level of assurity in medicine right now. And we need to strive toward that. And, for example, the surgical boards, let's just take the surgical boards, for example. We don't examine in technical skills. So you could pass my board with flying colors and no one knows you can operate or not. And that's something we have to fix. So we need more stability, parity, and more access, improved access for our patients. And that gets into a whole other discussion about insurance. And, they keep talking about insurance. Having a health insurance policy does not ensure you access to a doctor. I have the best health insurance you can buy. It takes 6 months to get a dermatology appointment in this city. So, having insurance, the politicians want to say, oh, everybody should have insurance and that's going to be the be all and end all. No. We have to fix the workforce problems, access to doctors, who's going into medicine, what specialties we need help in, et cetera, et cetera. It's a global problem. We need to redo the Flexner report. We're still operating on the basis of the Flexner Report in 1910. And the world has changed. And so we need to re-examine the entire system, from how we educate doctors, how we pay for their education, how we train residents, how we have patients insured, et cetera. The whole thing needs to be re-examined. And we're doing little piecework, and it doesn't work. It doesn't work.
It's fascinating. Obviously, not to get into politics, but clearly, we can't even, keep the government open. How is this going to happen if we are going to re-look at the Flexner Report of 1910? If
Yeah,
we're going to do the revamp that you're mentioning,
right.
and not to put you on the spot, but I'm just curious, like, how do you view that? How can that happen in a fractured system as we have?
Yeah. Well, first of all, uh, anyone who wants the federal government to run healthcare, all you have to do is look at what's going on now. If these guys were running medicine right now, we'd be in big trouble. I mean, seriously. So that's not the answer. However, leadership is the answer. Abraham Lincoln was one man. He changed the whole dynamic of this country, leadership. And one thing Lincoln did that we have to be mindful of, he surrounded with people who didn't agree with him. If you
Mm.
read Doris Kearns Goodwin's book about this, his cabinet was comprised of many people who didn't like him or didn't agree with him. He embraced those people. Leadership, if we could find a leader to get this thing off the ground and get people together around the table and have committees to do things around healthcare, whether it's education, whether it's access, all these different things. We have immense talent in this country. I mean, look at the American College of Surgeons alone. We have so many immensely talented people that could do this. We just need a leader to get them all together and get them working. Roosevelt did it. Teddy Roosevelt was the guy that got the Flexner Report off the ground, because he looked and saw all this terrible health care that was going on at the turn of the century into the 19th, from the 1890s into the 1900s. He said, wait a minute, we got all these storefront medical schools and whatever. We got to fix this. One guy got it all started. So it can happen. It's just leadership, in my opinion. One guy's view. Maybe I'm all wrong.
No, but thank you. That's a great view. This is related to something we talked about, and I see a question from Dr. Aziz. He says, Dr. Healy, I completely agree with your point about the risk of losing sight of patient care in pursuit of RVUs. From your perspective, what can surgeon leaders do to ensure that we preserve the soul of our profession and keep patient-centered values at the heart of surgical practice in today's finance-driven health environment? And I want to point out something we talked about in prep for this, which was this concept that we're all the same. You mentioned, we're all Toyotas or Chevys or whatever. And I wanted to put the two questions together, and your thoughts about that.
Yeah. Well, first of all, we've lost control of our hospitals. That's a big issue, in my opinion. And we've really come to the idea that medicine is a business, therefore it's got to be run by business people. Well, business people have a different view of patients than we do. I mean, you go to business school, you learn about how does Toyota get so successful in quality. Well, they have a standardization, they listen, they have all these plans. Well, some of that is translatable to healthcare, but some of it isn't. Not everyone with diabetes can be treated with a single page, 7 bullet point treatment plan. I mean, we have short people, small people, fat people, thin people, old people, young people, all these myriad of differences. So we have to recognize as leaders that we have not promoted that concept. We have stood on the sidelines, wrung our hands. Now what's happening with the young people? They talk about burnout. I don't think there's real burnout. I think it's frustration.
Mm.
People in medicine, whether they be young residents or staff surgeons or whoever they are, there's so many people frustrated because they can't practice the way they want. They can't be with their patient. They can't spend the time. So it's a frustrating thing. Our leaders need to address this. we are not visible enough as doctors in the American healthcare system. Isn't it interesting that everyone else in the world has come up with a healthcare plan for America except the doctors and nurses? And by the way, that's another thing we don't do. We don't partner with our nurse colleagues to solve these problems. You know, we're fighting with the nurses all the time. They're fighting with us, whatever. No, the nurses should be our colleagues. Think about the power that we could have if the doctors and nurses in this country were united behind a system that really took care of our people and took care of their illness. So I think it can be done, but it takes leadership.
Thank you for that. Thank you. So, the one thing that I wanted to make sure I ask is, in all of this, how did you integrate your family life and your personal life into the leadership world that you were in?
Mm. Very, very important question. It's something that I stress to the residents and the young surgeons that I was privileged enough to lead in my career. Never forget your family. They come first. I never missed an evening meal with my children. I would come home, have dinner with them, ask them about their day in school, get in my car and go back to the hospital, and sometimes be there till 1 or 2 o'clock in the morning doing paperwork or whatever. But I never missed having dinner with the kids for the most part. Now, if there was a dinner that I had to go to the hospital, whatever, but you understand where I'm coming from. You got to give your children and your family the sense that you care about them first and foremost. And your patients are a very important part of the care paradigm as well. But your family is the core of your life. They're the people that are going to be there for you and support you through thick and thin, and have the empathy when you're down and you have bad days and you come home after you may have lost a patient in the OR. It was always uplifting to be able to come home to my dear wife, who is now passed on, but she was always encouraging to me about, you know, it's going to be okay. You know, you'll do okay. So don't forget your family. Critical, critical, critical.
Thank you. As you think about your legacy, what are the things you're most proud of?
Yeah, I guess the things I'm most proud of is, first of all, my children. I have two beautiful daughters who are wonderful women, who are great moms, great professionals, uh, and they love their families. And you know, I'm very proud of them. And it takes it takes a lot of work. Parenting is not an easy thing, and it's a joint venture between you and your spouse. And so I'm proud of my family first and foremost. I'm so proud of so many of the young doctors that I trained who have now gone on and now are being immensely productive and contributing so much. You know, for example, one of my former fellows is now the regent for otolaryngology at the college. You know, and so I'm very proud of those people that I put forward. I'm also proud of my relationship with the staff of the hospital. You know, I I always tried to connect, as I talked to you earlier about, with the the people that I thought made the place run, the carpenters and so forth. Do you know, I still get invited to the carpenters' Christmas party at our hospital,
Wow.
even though I've been gone for so many years, and they remember that you cared about them. And I'm proud of that. I'm proud that they got the message that I really did care about them. So those are some of the things I'm proud of. And I'm proud of my service to the college. I love the American College of Surgeons. It has been such an important part of my professional life. I hope I've contributed a small amount to it, but I sure have learned a whole lot from my colleagues there. People like Sach and Patrice, who's on this program tonight, And I'm sure many of the people watching are people that I either was collegial with or partnered with or whatever. And lastly, I'm proud of the partners I had at Boston Children's. We had a tremendous department. They were wonderfully supportive of me all through my life as the chair. And so those are some of the things that really stand out and I think about a lot.
Excellent. Excellent. So, Dr. Healy, this has been an amazing conversation. Any final thoughts before we end the night? And I know Dr. Sachdeva will give the final comments, but
Yeah.
I just wanted to ask you if there were any final comments for those who will watch this later on and those
Yeah.
who are on right now.
Well, I think, it's been a privilege for me to do this, first and foremost. I'm most grateful to you all for asking me to do it because, after you've passed your prime, as they say, people may not want to listen to you. But, us old guys have some things to pass on. And by the way, I want to promote the senior surgeons group that's just been formed at the college because we have over 30,000 surgeons in the American College of Surgeons that are over 65 years old and are still can be incredibly productive. So look into that. But I just want to say thank you to all my patients, all those children that I was privileged to care for. Uh, they really made my life very, very special. And I'm grateful for them and their families. And I'm just, I'm very grateful for the opportunities. I've been very blessed in my professional life and in my private life. And so I just want to say thanks to everyone.
Thank you so much, Dr. Healy. It's been a pleasure. Dr. Sachdeva, it's all yours.
Thank you so much, Dr. Healy. You have shared so many pearls with us, and we are indebted to you for your wisdom. And you've covered so much during the conversation with Dr. Shabahang, and I'll just pull a couple of things that really have stuck in my mind. You have emphasized the primacy of patient care and how important that is. The importance of professionalism, role modeling that has to be exemplary, introspection, collaboration across the healthcare professionals, such as nurses and others. And in all this, you have emphasized the balance between the professional work that we do and the family that supports us each and every day. And what has really been a key item that has come through in this conversation is how a consummate scholar and a gentleman and a master educator and a leader of world renown and within the college, how someone can be so humble and down to earth. In fact, that is what we all admire about you. I've learned so much from you, and you have been able to do all this and yet remain grounded and humble. That is a message that we all need to take away from this evening. Thank you so much, Jerry, for joining us, for sharing all these wonderful pearls with us. Thank you, Mo, for, again, a masterful job in running the session. And thank you all for being with us this evening. It's been a marvelous conversation. And I know hundreds and hundreds of people, if not thousands, will view this recorded presentation after this session. So thank you all. Have a great evening and a great night. Thank you so much.
Have a great night. Thank you.